On a personal note, I want you to know that I approach this work as a nurse that has had to fight for my patients to be heard and their needs to be honored. The daughter of a person with a complex medical history and absolutely no trust in the medical system as a result of her experience, despite her daughter being a nurse. The wife of a veteran who has no trust in vaccines, which means you know that COVID vaccine conversation in my house. A patient who's been in a medical visit where someone was knocking at the door to tell my doctor to hurry up. And as a staff member who's had to fight organizational bureaucracy, hierarchy, and ego to get my patients' and fellow staff members' needs met. I do this work to heal wounds generations of old and generations yet to come. I do this work to honor the stories of survival, resilience, and heartache that have been shared with me throughout the years. I do this work as a legacy to my mother and as a gift to my niece. I want to point out that I introduce myself this way for two reasons. Although society and the profession of medicine care about the first portion where I list my degrees and years of experience, my patients care about my personal story, my personal introduction. Yes, they want to know that technically I'm a nurse, but what they care about most is that I can see and relate to them as a person. Secondly, I share my journey because it represents one of millions that exist in our world that has to navigate and mitigate the barriers we are fighting against through JEDI work, and is part of my why for doing this work. I really wish I was an octopus this morning because I could use one extra set of hands. This is the second part of my why. I honor and acknowledge the original stewards of this occupied land. We stand on the unceded ancestral lands of the, I'm gonna butcher this, I know. See, I was practicing beforehand. Thank you, Piscataway. And what was it? Hold on, see, in community. Just close your eyes and just say it.
Piscataway Conoy tribe.
Thank you. Deep gratitude. I respect and acknowledge these people, this tribe and these people, past and present, and honor with gratitude the land itself and these tribes. I honor and acknowledge indigenous wisdom of my ancestors and other tribes of indigenous people whose work has contributed to my work. My work is committed to uplifting and celebrating the wisdom held by indigenous communities here and abroad. I acknowledge the labor of Black and African people, ancestors, and their descendants. I recognize that the United States and global economies historically and currently rest on the ingenuity, cultural treasures, and stolen labor of African Americans and Black people throughout the diaspora. I honor the brilliance and humanity of all immigrant labor, including voluntary, involuntary, trafficked, forced, and undocumented peoples who's contributed to the building of this country and continue to serve within our labor force. And I express my heartfelt gratitude for their infinite contributions. By recognizing the land that was taken from the First Nations of indigenous people and the forced labor that was provided by enslaved Africans and Black and brown people, I strive to take steps towards creating a more equitable and just world for all of us. The indigenous people of Turtle Island, AKA colonized America, define soul wounds as the cumulative historical trauma that has been passed down through our generations. America's soul wounds encompasses the historical and current injustices that skew our perception of ourselves and those with whom we share this land. I intentionally share this as part of my land acknowledgement because everything that we see when it comes to health inequities and the social drivers of health, and the reason why we have to have JEDI conversations, persist because we have yet to do the work to heal these wounds in healthcare and all other systems that exist in our society. Every story of being judged, dismissed, or blamed for one's medical condition or social condition stems from these wounds. And although we are clearly not the creator of these wounds, we do own them through inheritance. Thank you, dear ancestors. When we do the work of JEDI, including developing a JEDI language for ourselves and our organization, the manifestation of these wounds and subsequent skewed perceptions that we have are what we are tasked with navigating and healing in the ways that we can by being able to acknowledge, hold, and address these truths. All right, so these are our grounding concepts for today. There are core foundational concepts that JEDI rest upon, but it is something that has to be customized so that its application and meaning has impact for those who are doing this work. So that is just to say, it is not cookie cutter. All the tools that I'm gonna give you today, you will need to take them, digest them, and then redesign them so that they fit your organization. So they have meaning for your organization. So they have meaning for the people who you are serving and for the people that you employ. Often people get stuck at the planning board. Planning, prepping. Planning and prepping is important, and perfectionism is a whiteness norm that we're gonna talk about later. So don't get stuck there. There will be oops, ouch moments, accept it. Plan for it, and by this I mean have an equity lens process in place, have a restorative process in place, and get to work. Don't let your desire for perfectionism, for doing it exactly right, stop you from moving forward, right? Because oops, ouches are gonna happen, and there is no exactly right to this. There is no prescription, right? You're gonna have to learn how to grow and pivot as your program grows. The more personal your why, the more meaningful it would be, and the better it will be able to support you when the road gets rough, which it will. Same thing for your professional why. The more meaningful it is to your org's mission or vision, the better. The system of whiteness has every intention of fighting to the death. For the system of whiteness, this is a zero-sum game, meaning that any progress that we make by doing this work, it sees as a death sentence. And if it has to choose, it's gonna make sure that it lives on, even at the expense of millions of others. So, you will be confronted by challenges frequently when doing this work. Those challenges may look like personal beliefs, to fragility, to fear campaign tactics, to stagnation, that whole mentality of, well, we've always done it this way, so it works, but does it really? Are you really just trying to stay in your comfort? To, we don't have the funds to do this. All of these are challenges that you're gonna need to navigate. Understand that doing this work at some point in the journey, you will lose privilege and comfort that whiteness has provided you. It's important to remember that privilege at the expense of someone else will eventually harm you as well on some level. Indigenous wisdom teaches us this. As I do this work, my intention is to sow so many seeds that I put myself out of a job, and I am looking forward to that day. Other people tell me it's not gonna happen until I'm 80, so I guess I got another 40-something years left. This work is about systemic access. I wanna repeat that, because a lot of times people default to the personal. And personally, I'm like, it ain't about you, right? This is about systemic access. So well-being and healthcare is a human right regardless of what body you inhabit. I use the example of something that I actually struggle with. I'm like, you cool in the binary? Yep, so am I. right? And because I know that if I condone the oppression of those who don't live in the binary, then I'm part of the problem, right? Because they deserve to have equitable health care too. They deserve to be seen as who they are, regardless of my comfort, right? Because again, it's not about the personal, it is about systemic access. The Black and the elderly deserve to be heard and believed when they seek care. People with lived experience of substance use disorder deserve not to be judged and have their needs met, and to be supported in navigating their definition of what well-being is for them at this point in their journey. Now, we are likely to disagree at some point. And yet again, when we are embodying this work, it's important that we remember and ground our actions in addressing the systemic, not the personal. Systemically, we all have an innate right to equitable access and protection. This work is labor intensive. It is important that we personally and as organizations acknowledge this and put practices in place to help support the required emotional labor of this work. So we're going to talk about what it looks for us personally later in our slides. But professionally, this means beefing up your employee wellness program, incorporating affinity groups, normalizing the use of PTO for mental health days. If I am doing this work and I am struggling, or actually even if I'm not doing this work and I happen to be struggling, I need to be able to call in sick and not lie and say I got diarrhea, right? I need to just be like, yo, it's a rough mental health day today. This means sending our leaders to trauma-informed supervision training and ensuring that our culture of the org is one of healing for our staff and not just our patients. Developing the work of a JEDI language consists of being able to see the practices and policies that reinforce marginalization and oppression in our organizations, being able to name and discuss what we see and find. And then it's about creating a plan of action to disrupt the practices and policies that we have found. And so this is the journey we're going to do today. So, quick question, just a raise of hands. How many people are comfortable with the foundational concepts of justice, equity, diversity, and inclusion? Okay. All right, so then I'm going to try to go through my foundational piece a little quick. All right, so during my initial years in healthcare, I took my training at face value. As the years passed, I began to think about the business of healthcare and wonder, where did our medical knowledge come from and at whose expense? Before, we were synthesizing medication in labs, plants and herbs were our medicine, and who were the keepers of this medicine? As I stood by and watched my limited English-speaking families, my undocumented, my elderly, my unhoused, my Black and brown patients all struggle to navigate the system that was supposed to help them cultivate health and wellness rather than add to their burdens, I tried to understand as a healthcare professional, what were we missing? At first, I thought it was simply a gap that had to be bridged. And as I began to look for solutions to bridge that gap, which I have a vision board at home, being like, okay, I just need to bridge the gap, I realized I needed to step back and actually look at the container in which we were doing healthcare. So, when I looked to tackle the struggles that were faced in every patient visit that I had, I realized that the container in which we provide medical care, the waters that we swim in, are waters of whiteness. The waters we swim in and thus provide medical care in is built on a hierarchy of societal norms that support a white cultural view of the world. This culture of whiteness is designed for a very specific demographic. Its norms cater to the white, Anglo-Saxon, Christian, middle-class, educated, able-bodied, heterosexual, middle-aged male people. This means all of us who fall outside this norm are considered deviations, and as a result will innately struggle within any system built upon this norm, which is every system in America. In a debate with W.E.B. Du Bois, Harvard graduate, writer, and historian, Theodore Stoddard argued, "We know that our America is a white America, and the overwhelming weight of both historical and scientific evidence shows that only so long as the American people remain white will its institutions, ideas, and culture continue to fit the temperament of its inhabitants and hence continue to endure." I want to point out that for Theodore, it isn't just a black and white issue. His thoughts applied to all people of color and anyone who didn't fit into the hierarchy. As you heard that statement, can you see how that mentality continues to permeate the world that we live in today? Now, I do fundamentally believe that the vast majority of us are not trying to sign up and be complicit to a system that brutalizes and murders fellow human beings. And yet, as the timeline that we're going to go over will show, these systems have been in place since the colonization of this land and continue to influence us. And because it was set as a cultural norm, it is just seen as the way things are. The system of whiteness knows it is very important that we are unable to accurately describe what is happening in systems of economic, cultural, and political power. Because in order for the system of whiteness to remain in place, it needs us to continue to do nothing. In order to stifle our outrage at just how unjust the system of whiteness is, we have to be unable to describe it. It has to be this vague nothing that we can't make any progress against. It's the reason why there is such a strong fight against a multicultural view of history. It's why we are taught to work in silos rather than coming together. There's too much risk that we will connect the dots. This vagueness narrative is what I and others committed to JEDI work are looking to disrupt and dismantle so that healing can thrive in its wake. We are very clear on the impact of adhering to a system of whiteness for all racialized people. That means white people too. But especially for those who fall outside this hierarchy. Our patients who fall outside this hierarchy are very clear of its impact on their lives, their quality of care, and their overall well-being. And so are our staff members. And even if we don't clearly recognize the source as healthcare professionals, we too know its impact because it's the poor health outcomes and disparities that fill our quality metrics. In doing the work of addressing health disparities and inequities, one of the most important things I learned was to see how these waters inform all that we are fighting against. Who knows healthcare's legacy of whiteness? Just raise a hand. Okay, a little less. Let us start that journey. So the container of healthcare's legacy is as follows. And I want you to think about Theodore Stoddard's quote that I shared with you as I share this timeline and the practices that I say that we need to disrupt. So, the 1800s, science and religion created justification of race-based treatments of humans, which paved the way for the following. Vaccination experimentation started with Thomas Jefferson. So Tuskegee was not the first. Surgical experimentations. The most famously known and praised is Dr. Sims, the father of gynecology. This man got statues all over the place. He is in art galleries. And he is the man who learned and perfected his technique on unsedated female slaves. He operated without anesthesia, claiming that blacks didn't feel pain. And I want you to remember that because it's going to come back up again. It's over 170 years later, and this myth still remains in our medical community today. In 2016, a medical study found that in a survey of 222 of tomorrow's doctors, white medical students and residents, half of 222 people endorse false beliefs about biological differences between blacks and whites. Genetically, we know that when it comes to differences between us, we are actually 99.9% the same. There's like a 0.01% that has some different earwax, but everything else we're the same. 40% of first and second year medical students endorse beliefs that black people's skin is thicker than white people's. A 2019 study that asked subjects to identify pain expressed in photos found that white participants more readily recognize pain on white faces than black faces. And if you think that it's just then, I'm like, this narrative of black people not being human was seen when Dr. Susan Moore died of COVID after not being believed that she was having pain, after not believing that she was suffering, right? Even though she was a practicing physician. It is Serena Williams who, despite being a world-renowned tennis player, almost died due to not being believed that she was short of breath after having an emergency C-section due to a blood clot, even though she had a history of blood clots in the past. And so for all my medical clinical people, you know, if somebody has a history of something, the likelihood of it coming back again, right, is high. But they kept putting her off. But Serena wasn't having it. And so she kept demanding that they do the test that she knew, even though she wasn't a clinical person, she knew needed to be done. And they found out she did have a blood clot in her lung that if stayed there would have killed her. It's women of color and elderly people frequently not being heard or believed within our medical system. Taking a step back, 1900s brought us the eugenics movement. Eugenics was a commonly accepted means of protecting society from the offspring of those individuals deemed inferior or dangerous. This included the poor, developmentally delayed, the disabled, the mentally ill, criminals, unmarried mothers, immigrants, and people of color. Disproportionately affected were and are Black, Puerto Rican, and indigenous women. The last state to repeal its law on eugenics was done in 2003, and it was in North Carolina. Stories are coming out telling how forced and coerced sterilizations are still being practiced in Puerto Rico and in other states in the US in our correctional settings and immigration detention centers. 1945 to 1962 brought us radiation experiments with more than 210,000 civilians and GIs being exposed to radiation without their knowledge. And I want to pause and ask you to think about who typically signs up for the military. What patient population is this? As early as the 2000s, military recruits were not being told what was being administered to them when they had to show up for vaccinations. Again, for my clinical people, when I heard this, I was like, what? So when you're in the military, I'm like, they call you, you get into a line, and you get into a line, they give you your shot, and then they ask you your number. Like, what's your military number that identifies you? Now, you know, again, as clinical people, we don't you supposed to identify the patient first. But yeah, my wife watched as a fellow Marine was dishonorably discharged because he refused to take a vaccination series that was having severe side effects. She took half of that series before it was finally discontinued because of the harmful side effects. Unfortunately, it was 6 months after he was court-martialed and dishonorably discharged. Is it any wonder that our veterans today get mislabeled as resistant or non-compliant? We need to pause and think about why. 1932 to 1972 brought us the Tuskegee experiment. Right? I recently talked to our Vaccine Ambassador Program participants. So these are people who are from the community who go out and try to encourage people to get vaccinations, including COVID, right? Because that's when it started. And many of the Black men, both young and old, named the Tuskegee experiment as their reason for not taking vaccinations. We also still have and use race-based medical algorithms that diminish the risk of illness for us and the severity of our illness that we experience, despite evidence showing that we have poorer health outcomes. So an example is, and this one is actually in the process of being revamped. I was happily told this back in March. But there's a cardiac risk score. And if you go in with cardiac issues to the emergency room, they do this assessment on you. And if you are a Black person, you automatically score 3 points lower. The higher you score, the more you'll likely get referred to cardiology. Yet when you look at the CDC website and the top 10 things that kill Black men and women, what do you think you find? Yes. Right? Same thing. There's a vaginal birth assessment score. So for women, if you've had a C-section in the past, they have you do this assessment. And Black and Hispanic women are ranked lower, right? And so what this does is it means that they are not given the chance to do a trial natural birth. And having a vaginal birth versus defaulting to a C-section is important because it actually has better health outcomes for the mother and the baby. And yet, Black and Hispanic women are automatically ranked lower, so we are not given that chance. And yet, the maternal infant child mortality rate, right? And so these are things that we're actively using. Okay, I'm off my soapbox. This timeline clearly demonstrates how the system of medicine is a product of the container of whiteness and reinforces the narrative of bias, oppression, and who is deemed as disposable. The very people in this timeline that have been deemed as disposable are the very people who are struggling with poor health outcomes and health disparities today. This is not a coincidence. These are the containers and mindsets that we are looking to disrupt and replace with practices that center healing and When doing the work of JEDI, we are not going to be able to voice, sorry, hold on, let me back up. My words are getting mixed. All right, when doing the work of JEDI, we need to not only be able to voice these truths, but more importantly, we need to disrupt these practices of scientific racism and bias and that reinforce this legacy which these containers were founded upon. This is the role of championing and leading JEDI work in our hospitals, clinics, medical training institutions, public health departments, and every other program or organization that provides health services. We are called to be disruptors of harm. What we do not disrupt, we are complicit to and thus condone. I'm gonna repeat that. because some people I talk to have the impression that I do this job by choice. This is not a choice for me. This is my survival. This is the survival of my mother. This is the survival of my niece, right? What we don't disrupt, we are complicit to and thus condone. Okay, so what the heck are we gonna do about this? So in order to address this, we need to do work on multiple levels. We need to see what's occurring on the interpersonal level is actually fueled by our internal narratives, our institutional narratives, and the structural and systems level narratives. This means we need to start within ourselves as individuals and organizations, and from there we can come together as the cultural, political, and fiscal superpower that we are, because let's be honest, healthcare has become a business, right? And we can actively demand the changes we know are needed both inside and outside of our clinics. Because the truth is, we know that what we do in our clinics only account for 20% of our patients' well-being. 80% is the stuff they have to navigate outside our clinic walls. And yet, when they come to us and the blood pressure isn't better, the diabetes is under control, what is the first thing we do? Who is the first person we start pointing fingers at? Right? The patient. Not asking questions like, what got in the way? What do you need help with? Was this actually an achievable goal for you? Was this realistic? Right? What do you have to navigate outside? What are the barriers outside? Because we automatically assume that the barriers are inside the person. We just need to change that person. When really we need to change the system that person has to live in and navigate. So, we can never help to truly address the challenges faced by the people we serve, nor achieve health equity for our staff, our patients, and their families without addressing the public health crisis the system of whiteness exists within ourselves, our orgs, and our community at large. I want to point out that when I do this work, I always start with and center race because that's how the soul wounds of this land started. And I utilize intersectionality because our identities don't exist in a silo. So as we're doing our work today, I want you to always think about intersectionality. And so intersectionality is a term coined by law professor Kimberly Crenshaw. It is the overlapping and intersecting social identities and related systems of oppression, domination, and multiple forms of discrimination. All that to say is, it's racism, sexism, ableism, homophobia, right? It's all of those things. It's a lens that allows us to see where power collides, intersects, and interlocks. Intersectionality is important because not only to ensure that we are not marginalizing the communities that we are serving, but also to make sure that as we're trying to empower one marginalized community, we don't go on to marginalize a different community, right? We don't want to replicate that pattern of harm. So, as we do this work, it's not simply about race or class or gender or sexuality, it is all of these things, which can combine, intensify, mitigate, or contradict each other. An example that I'm gonna give you later, it's like, oh, it was one marginalized person was like marginalized in one area of their life, privileged in another area of their life, marginalizing somebody else. So like that's the reason why we have to like always check that intersectionality lens for ourselves. The container of whiteness norms attempts to force us and others to put our identities in a hierarchy at the expense of another. This was part of a talk that I actually gave last year. When we design our programs, right, it's just like, oh, well, I am like, this program is for homeless youth. So, but what about the homeless youth who's also part of the LGBTQIA plus population who's also limited English speaking, right? Do we think about that as we're building that program for homeless youth, or are we making that youth prioritize which identity they're going to be served for today? I say that there can't be a Black Lives Matter movement without taking into account all of those people who make up Black lives. So this means that your disabled Black queer sister's life and struggles are just as important as the Black heterosexual male struggles. In the case of our patient populations, like I said, our current advocacy model often makes our clients choose. And so for the Black female who is experiencing homelessness is not the same as the Black elder trans woman who is experiencing homelessness, or a Latinx non-binary queer youth with English as a second language who recently immigrated. Yet often, our programs still require them to work in silos and identify which need am I going to address today. It's imperative that as we provide support, that we are training our organizations to develop their services with ample flexibility and versatility to empower staff to meet the intersecting needs of the people that we serve. On your table, you have a handout with an iceberg on it. It is also uploaded. If you haven't looked at the handouts that are uploaded in the app, I'm pretty sure, I'm gonna have Brett check. I'm pretty sure I'm gonna win like most uploaded handouts. I was trying to save trees. And I wanted you to have resources, right? Because again, this is not cookie cutter. You're gonna have to develop this. You're gonna have to learn this. And so on this handout, it actually explains what each of these levels of the iceberg looks like and gives you examples. So hold on. Oh, this is JEDI. We all in community, which means yes, you do have to share things. Again, I was saving trees. I'm like, you were supposed to share with your neighbor. Again, you have the electronic copy of this, so you will have your own copy of the handout. Oh, okay, and I will follow up on that. I just heard that somebody had issues downloading, so I will make sure. Oh, okay, and then I was just told they should end up on our website later. And at the end of the slide deck, you will have my contact information, which means you can email me like, Kevonya, none of that worked. Can you please send me what you know I need? You can. Give me a week turnaround, but you definitely can. So on this handout, I just wanted you to be able to look and see. And so you have a definition to work with, being like, okay, what is interpersonal racism and bias? Like, how is that defined? And what are some examples of that? And an exercise that you can do with your organization, because again, part of doing it at JEDI language is being able to name the practices and policies that are within your organization, right? Because what happens in my organization is probably different what happens in yours, how it manifests. And so this is a great handout to use to help being like, okay, well, what does this look like for us? Any questions? Okay, and you even got the highlighted version. Yes?
Is part of the workshop going to be how exhausting all this is to stay on top of?
I'm like, you needed to join me yesterday. Yesterday we had an affinity group for our JEDI people, and it talked about the emotional labor of this work. And so, yes, I did literally add that at 8 o'clock this morning. The question was, are we going to talk about like the emotional labor that is involved in doing this work? And so that's because this used to be an exercise that we were going to do in person, but now we're not. so that I can allow some time so we can actually talk about the emotional labor, what that looks like, how do we name it, how do we ask for what we need so we can be supported in doing this work, and nurture and take care of ourselves. Okay. So, as we're looking to develop an organizational language, we need to be clear and understand what JEDI actually means. What are we looking to address when we're saying that we're trying to do JEDI or EDI, which is equity, diversity, inclusion, or equity, diversity, inclusion, and belonging, right? So we're gonna review some really foundational concepts. And I want you to pause and think about how the following concepts come up for you personally and within your organization. So the first concept is whiteness, which we talked about, right? This is the hierarchy that prioritizes the white, Anglo-Saxon, male, educated, able-bodied, middle-class, heterosexual, middle-aged Christian at the top, and everyone else as some classification as less than or other. There is white gaze. This is a concept most notably articulated by Toni Morrison, explaining how we all have been socialized to consider white perspective and formulate our behaviors with the opinion of whiteness in mind. Even as I write this training and others, I constantly struggle with white gaze. There is an unspoken narrative that none of us who fall outside the system of whiteness are ever to cause discomfort or disrupt the presumed right to comfort. I am always supposed to default and bow to white gaze. Again, I point to the perspective of multicultural teaching. That is a perfect example of white gaze. How dare we want our history told without the influence of whiteness? My grandmother, one of my grandmothers, was born in 1932. It was the year that Tuskegee started. She was 40 when it ended. How do you think that influences her when she goes to the doctor? When they say that we shouldn't talk about our history or that we should not teach, right? Critical race theory, which literally is just a multicultural view of history. How do you think that makes her feel? The concept of right to comfort is a frequent disruptor of JEDI work. We don't want to upset anyone. We want everyone to happily join this work. But the reality is, tending to these wounds and doing this work of healing is often uncomfortable. And some people will not be willing to endure the discomfort necessary to cultivate healing. Accept and plan this. Accept and plan for it. Ask, why is their presumed right to comfort more important than healing and addressing the oppression of others? Find out what narrative is feeding their assumption for them. Often when we can root and ground into people's narrative, we can usually find a common point to help us move forward together. Usually it's a lack of fear, lack of understanding. Right to comfort can also trigger marginalized groups to replicate acts of harm in the name of justice for themselves, which is why intersectionality is so important. In our society, in addition to white gaze, we also have male gaze, which women continue to need to fight against, right? We're battling that battle right now. There's heterosexual gaze, which is the battlegrounds for the LGBTQIA+ community. And all of these gazes show up in every patient population, in every room across America. And so I want you to take a moment and talk amongst your table. What are the gazes that inform your policies and practice at your organizations, and how do they manifest? You've got 8 minutes. All right, my lovely people. I promise, I'm like, in 3 minutes, I'm about to give you more conversation. Oh. All right, come back to me. Thank you, thank you, thank you. Another concept that I want you to think about, in addition to white gaze, is white fear and white rage. So, scholar Carol Anderson defines white rage as policies that undermine African American achievement and advancement. These policies sanction the violence that accompanies white rage to make it look legitimate. White rage is about controlling marginalized people through policy. White rage is the consistent response to African American women and LGBTQIA policy advancement. Again, if you just think about what's being fought in our legislation right now, that makes sense, right? White rage is, and white fear is the response to how dare we challenge or not bow to the decorum or sensibilities of white gaze. Heather McGee connects it to the false belief of America being played at a zero-sum game. When there's any advancement of the BIPOC population or any other marginalized group, whites see it as a loss to them, while the BIPOC community sees their progress as not taking away from anyone. Professor Jonathan Metzl connects it to racial resentment, and similar to Anderson, has seen it play out with whites supporting, or not supporting as the case may be, policies in which turn actually hurt them. But as long as it doesn't help the BIPOC community, then they're willing to suffer the consequences. I want to name that a similar dynamic plays out when it comes to women and LGBTQIA+ and immigrant policies. White fear in our work looks like the nurse practitioner who eased herself into the corner during my patient visit. He was a 55+ Black man. She was afraid because he became triggered due to his prior experience in the healthcare system, even though I calmly sat between them and he never came towards either one of us. It can look like questioning the purpose behind having a JEDI training. That is also white fear, being like, why do we have to have this conversation? And actions, or trying to figure out what is the threshold. The question came to me being like, well, how much of this JEDI policy or how much of this JEDI language do I have to follow? They're trying to find the threshold to figure out how can I toe the line just enough not to get fired, right? That's white fear. White rage is the Pittsburgh Tree of Life synagogue shooter that targeted the synagogue because they were working with the Hebrew Immigrant Aid Society and supporting immigrants and refugees. In this case, 9 organizations was doing this work. 5 of them were Christian. Only 1 was Jewish. When I listed that hierarchy, who else was on there? Christianity, right? It was the insurrection that happened on January 6th. The Black and brown community knows if it was us who led this revolution, the narrative wouldn't be patriots getting out of control in a peaceful protest that got out of hand. No, we would have been shot on sight, and the narrative would have been, as it frequently is, they are trying to take over our country. We need to arm ourselves against them. See, they tried to burn our capital, which ironically enough was built by slave labor, by the way. And like Anderson points out, white rage is a strategic use of policy and practices to help ensure the hierarchy of whiteness endures. In our work, white rage looks like a colleague of mine having to intervene recently when a white gay male verbally attacked one of their front desk staff who happened to be a woman of color. He repeatedly called her out her name. When a white passing leadership showed up, his demeanor completely changed. Upon apologizing, the white passing to the white passing leadership, right? He didn't apologize to the sister. The leader told the front desk person who was just verbally abused to find him an appointment like nothing happened. What message did that send to the patient, and what message did that send to that staff member? This is that intersectionality piece, right? Because you're like, oh no, he's a gay man, he's oppressed. I'm like, yeah, he's also white and male, which means he's also privileged, right? I'm like, so just because you are marginalized in one area, if you are not mindful, you will replicate, right, the waters that we swim in, and you will engage in behaviors that are oppressive and harmful to other people who are marginalized. All right, I want you to think about, I told you, I was like, I just need 3 minutes to like give you one more thing to chew on, and then you can talk again. So how does white fear show up for you and others in your organization? What patients frequently get blamed for their issues without looking at the larger picture? Which get labeled as non-compliant or challenging? What are the policies that get enforced for some but not all? And if you have issues and you can't think of nothing, that's fine. I want you to go back to your organization and look at your incident reports. What patients get dismissed the most from your organizations? What patients get security called on them? And who bears the brunt of verbal attacks from patients by your staff? And what population do these people belong to? And I'm gonna like have you stretch, right? Because this can be social economic based, so your bus takers, it can be social culturally based, your single parents. Think about, because we ask ourselves in our subconscious, like, why aren't they fitting in? Why aren't they adapting better? Why can't you pull yourself up by your bootstraps, which drives me nuts? Why can't you get yourself together? All of this is usually done without any thought to the container that the person has to navigate and live in. And I also want to point out that fear and rage can be directed at staff too. Why can't you make it to work on time? Why do you call out so much? Again, think about our bus takers, our single parents or caregivers. I had a coworker who was a single mom, and she had to drop her kids off. And so frequently stuff would come up. And so I'd be the first person at the clinic, and I'd make sure everything ran appropriately. And because of the culture that we cultivated on our team, that was fine. Because when I had an issue, right, she also gave me grace, right? If I was having a bad day or something happened, I needed to leave, right? It was cool. We covered for her in the morning. She helps us out when she can too, right? But if we were, and the executive leadership above her had no clue what was going on because we never talked about it. We cultivated amongst our team. But think about other situations. When I think about the clinics where other clinics I've worked at, if somebody constantly had to come in late, what would happen to them? Right? They'd be written up. They would be identified as a problem without taking into account, right, everything else that they have going on. And so that's another manifestation of how whiteness can show up. Think about like your single moms, your single dads, right? Sometimes they need a little grace. Acknowledge that, right? Your bus takers, sometimes things are out of their control. Acknowledge that. And yet, the policies often apply grace to some, but not grace to all, whether on the patient or staff side. Okay, all right, you got another 8 minutes to be like, all right, we're gonna talk about what gaze and rage and fear. Go for it. It was. I'm sorry. I set a timer. I promise. Don't worry. Like there's more. I promise. There's so much more. I'm like, cause y'all gonna be drafting definitions together. Y'all gonna draft a sample EDI statement together. Y'all gonna be in community all day today. Okay. Thank you again. I totally appreciate. I love that. Y'all are in such intense conversation because part of developing a language, like I said, is being able to identify how this stuff is showing up. You can't be trying to be like, oh yeah, we're gonna be doing JEDI, and not knowing how it actually manifests, what you're trying to dismantle and disrupt in your own organization. Okay, so when doing this work, With organization, there's an additional lens that I utilize. The Waters of Whiteness norms provide organization with their own set of additional practices, and it's extremely important to understand how whiteness tends to manifest itself in these spaces. We can't hope to make meaningful change if we're not able to address the container in which the change needs to occur. Hence why we are practicing, how does this stuff, how does white gaze, how does white fear, right? How do these things show up for us? Because we need to identify it in order to change it. All of these practices and socialized norms, when used at the exclusion of anything else, reinforce whiteness, which we know is rooted in oppression and marginalization of others. When we are looking to disrupt organizational whiteness norms, we need to suspend either or thinking and embrace both and. For example, I always use the paycheck example. So perfectionism, you'll see is number one up there, right? That is a whiteness norm. And every 2 weeks or every month, however your pay schedule work, you really want the financial department to be on their game, right? Because you want that paycheck. I don't know if there's anybody in this room who does this work for free. I don't. But we want them to be on their game. And, right, when we apply perfectionism exclusively, it can still be harmful. I listened to a talk last week from a chief financial officer who says that even in her work, a 1% error rate with a plan of action to correct is still acceptable, right? So we don't want, it's not that either or, we have to be perfect. No, like I want you to be darn near perfect on some things, and I also need to be able to extend grace, right? Because otherwise, people who worked for the Department of Finance, right, would be very miserable knowing that they have to be perfect all the time. That is an unrealistic expectation that shouldn't be put on anyone. So, if we apply these things to the exclusion of anything else, an adherence to perfectionism can cause an organization to develop a punitive work culture, because it means that if you are human and make a human mistake, which we all will make, right, you would be punished. An adherence to concentration of power reinforces toxic hierarchy culture, which does not support equity practices and gets in the way of truly embracing and supporting a diverse workforce. An adherence to right to comfort is likely to contribute to a lack of psychological safety when engaging with each other throughout the organization. An adherence to individualism gets in the way of seeing the value of collaboration and teamwork. An adherence to progress being bigger and more skews how we define and acknowledge success and contributes to an imbalance between what is expected versus the resources available, which I know we all have experienced in this room, right? They're like, this is what I want you to do, and this is what I'm giving you to do it with, right? Now, and intersectionality also influences how these norms show up and how they impact us. So, on your table, and I'm telling you where the handout is so that you know that you have this. I saw a couple people taking photos. Again, everything's going to be uploaded. But on your table, there's a packet that says Racial Equity in You. And it literally lists out all of these organizational norms, and it lists out antidotes. And again, remember, there's only 4 copies at the table, so remember, we're in community, we share. And you have an electronic copy of this on the in the app. Yeah, yes, it is multiple pages. It is multiple pages. And I like this one because it not only defines what these whiteness norms look like, but it also gives you antidotes. What are some other things that you can do? All right, Everybody got enough copies? Because you're gonna be using it later. Everybody figured out what I was talking about? All right. And again, nothing in this project is cookie cutter. These are starting points for you so that you can adapt and find anecdotes that are meaningful for your organization, right? These are definitions so that you can get you started. Okay, being a champion of JEDI means that we are not only aware of our privilege, but we utilize it to disrupt the harm when we see it. It is important that we do not rest in our silence, that we do not distance, deflect, or turn a blind eye to discomfort or risk losing said privilege, right? Remember, I told you, I'm like, when you do this work, be prepared to lose something. What privilege are you willing to lose in the name of this work? I want you to think about someone or some topic that causes you to tense up when you know they're on your to-do list. What patient do you regulate to the bottom of your list? What duty do you regulate to the bottom of your list, and why? And how bias and stereotypes might be at play here. So for me, when I was doing clinical practice, it used to be my patients who utilized meth. And definitely my patients who I classify, I want to specify, I classify as non-functioning alcoholics, right? Which that statement within itself is a multi-layered bias. Whose definition of functional am I using, right? And because I am such a firm believer in walking my talk, when I noticed these biases showing up, I had to step back and do my own internal work. And while neither are still my favorite patient population, I will not lie and be like, oh yeah, I fixed it. Nope. I can say that when engaging with these patient populations, I no longer sense a dread or anxiety. And when I'm called to provide care for them, I can clearly say and know in my heart that I provide culturally responsible and equitable care for them, as evidenced by their feedback, not my perspective, right? Because with my clients who utilize meth, it was just like, oh goodness. I would have this sense of dread, and it cued me, because I do a lot of self-reflection work, which is required as you do this journey. It cued me, I'm like, oh, this is not in alignment with who I know myself to be, nor is it in alignment with who I want to be. And so I started digging, and a common process to use is called the 5 whys. You can look it up and Google it anywhere. You also can email me, and I can give you my handout. And so I took my statement being like, patients who utilize meth are difficult. And so I would ask myself, why? Well, because they don't know what they want. And again, there's another bias, right? Because it's my perception that they don't know what they want. And so I just kept digging every time I would have an answer, I'm like, why do I think they don't know what they want, right? Because my first response was, well, they don't know what they want. Well, nope, let me step back. Why do I think they don't know what they want? Well, because whenever I engage with them and try to address their issue, right, they don't let me, or they're never happy, right? They never follow my recommendations. Okay, well, why is that a problem? Well, because I'm trying to help them, right? And so I got to the point where I realized, oh, my frustration with them was less about them and more about me. Right? Because when I engaged with them, they made me feel bad, because like all of my nursing, which like I told you earlier, right? I'm like, I got decades of nursing experience. All of that nursing experience meant nothing, right? All of the knowledge that I held meant nothing, because I couldn't meet them where they were, right? And it made me feel incompetent. It made me feel like a failure, right? And so I'm like, oh, well, I'm centering me. That's the problem. So I went to a colleague who also works with that patient population and does it well. And so I'm like, okay, yo, look, apparently I got this bias. I am not cool with it. I need to figure this out. What do I do? And so he was like, well, if they're in the midst of a high or coming down out of a high, like there's actually not a lot you can do. And so he recommended that I give them something to drink and something soft to eat and just hold space for them. That's it. Just simply hold space for them. Now, food is my love language. So I'm like, oh yeah, I can do food and drink. That's not a problem. And so that became my focus. When I was called to engage with care for them, I'm like, my only goal in this session with this patient is to give them their juice box, give them their gummy bears, and hold space. I was like, okay. And so that's what I did. And as I continued that practice, I noticed that my sense of dread and anxiety significantly decreased. And sometimes they let me do stuff, sometimes they didn't, right? But again, my only focus was to hold space and make sure they knew that they had a snack and that somebody cared and was holding space for whatever it is that they wanted to share out. And the biggest gift that I got was as I was walking down the hallway one time, because again, I worked in permanent supportive housing, so I was in their location. I'm walking down the hallway to see another patient. One of my clients from that patient population was in the hallway with somebody else. And this client never let me do anything. I'm like, please let me take care of your wounds. I just want to clean it, I promise. Just let me just spray a little bit of cleaner and put a Band-Aid on it. And it was always no. She would take my Band-Aids, but she would not let me do anything. But as I'm walking down the hallway, I hear her say, hey, that's Nurse K. She's always really nice to me. And I'm like, I didn't do nothing. All she got was her juice box and her candy. But I always, again, just held space. I was always a welcoming space. And because of that, I'm just like, okay, well, I know one day she'll trust me. And one day she did. It still wasn't a consistent thing, but sometimes she would let me take care of her wounds. She trusted me enough to do that. And more importantly, I addressed my bias. So that's what we need to do, right? Whether it's with our patients or with that staff member that just triggers us a little bit too much, right? Oh. All right. I want to say that a bias, whether protective, society-based, or unintentional, must always be addressed, and a valid why does not justify a universally applied bias. Does that make sense? So, I am a sexual abuse survivor. I have a male bias. In many circles, that would be seen as justified. And I had to tackle that bias when I was put in an all-male 55-plus building as an outreach nurse, right? And so again, I had to check my bias at the door and make sure that I met my patients where they were at and for who they were, right? Because even though I have my bias, it is not okay for me to universally apply it to everyone. And so this is especially true when you're committing to work from a place of championing JEDI. What we do not take time to cultivate awareness around, or what I call self-knowing around a bias, stereotypes we carry will manifest themselves with our patient and staff interactions, and will influence how and what policies we enforce and which one we approve or suggest to be developed. I cannot tell you the number of times fragility and intent has been the response when I've needed to call people in or organizations in on behaviors and practices that reinforce whiteness. It is so important that we not get lost or derailed by fragility. Fragility is often grounded in personal feelings or belief. The work of health equity and JEDI is about what? What did I say this is about? Systemic access. It is not about the personal. And so personal feelings do not justify limiting systemic access to resources that meet patients' self-identified needs. And although white fragility is the one that we know the most, coined by Robin DiAngelo, there is also male fragility, cisgendered fragility, heterosexual fragility, able-bodied fragility, right? Fragility is typically rooted in an area where a person holds privilege. Fragility can combine with a right to comfort, which is one of those whiteness norms, right? And cause us to choose not to do something. Someone had tapped me being like, hey, how would you categorize the provider who doesn't want to ask the social determinants of health question because it makes them uncomfortable? I'm like, well, that's their white fragility and their right to comfort coming together and being like, well, that's a tough topic and it makes me uncomfortable, so I'm not going to do it. We need to recognize that being human is sometimes a messy experience, and the journey of healing is rarely without some degree of messiness. There is no perfect way to do this work, so let's get that out of our head. Even as I do this work, I too have oops, ouch moments, especially when engaging with social groups I don't have a connection or membership with. For example, like I said before, I'm a cisgendered female who lives comfortably in the binary. And although I'm getting way better at defaulting to a they, them, which I'm very proud of, I still struggle with some neopronouns, right? So, and our neopronouns are like they, them, they, zir. As someone who facilitates JEDI training, my intention is clearly one of not causing harm, and I want to promote healing. And I still have to reckon with my impact when I make these oops, ouch moments. Because of our societal programming, none of us are an exception to whiteness. I want to repeat that, because us do-gooders are like, no, I'm a do-gooder. I am fighting the good fight. I ain't the problem, it's those people. We the problem too, okay? We have been swimming in these waters of whiteness. We have drank the assimilation Kool-Aid. And so there is something in us that also needs to be addressed. And when we rely on intent rather than reckoning with our impact, it's like saying, I'm sorry you feel hurt, which is not the same as I'm sorry I hurt you. So when you're called in your bias or behavior that marginalize, it's important to be mindful to take responsibility for your impact and not try to justify it with your intent. You also need to know how to navigate microaggressions. In the example I provided earlier where the NP found herself being triggered by my patient being triggered, as the outreach nurse, I could have asked her, I may be totally off, but I'm sensing that you're afraid right now. What do you think is behind your safety concern or fear? Because remember, I'm sitting calmly in between them. So if he gonna do something, he gonna reach me first. Can you tell me more about the thoughts you're having? What has contributed to you having this perspective or narrative about this patient? Because he's never been with her before, which means he's never heard her before. She's just going based off of assumption. What stories do you hold for this patient population? So another one of the handouts that you have is a handout on navigating difficult conversations. It has a little lotus flower at the top. The focus of this handout is to help you pause, take a breath, and then engage from a place of curiosity rather than reactivity. It lists questions to help you prompt what I call other knowing, so we can get to the root of those stories that people carry. So we can start cultivating a space where we can have conversations and get to the root of microaggressive, macroaggressive statements. And if you are the one experiencing the microaggression, macroaggression, you don't have to do this in the moment. You don't have to do it at all. You can totally tap a leader or an ally, right, to have this conversation. Because we already bear the burden of dealing with the micro and macroaggressions. But if you choose, I wanted to give you some tools. In part of the uploaded packet, you also have 2 more handouts on microaggressions, being like, patient said X, you can respond Y. Okay? These are great tools, again, as you're building a JEDI language, tools to share with your organization and your team so that you can practice, right? So everyone has this skill. Everyone can disrupt when they witness microaggressions against someone else. Or if you're having one of those moments where somebody caught you on the right day at the right time, you can have a response rather than a reactionary comment. Yes.
I'm just curious, what's staying with me is the example that you gave at one of the organizations you were working at, where the African-American receptionist was confronted by one of the patients, and the provider came out and told her to just make an appointment and then make him an appointment, and then did someone go back to the person? In other words, did somebody point out to the provider what had just happened, and how was that resolved?
I am happy to say that as a result of the equity work that was done at that organization, that staff member was allowed to go home paid, right? Because thank goodness, because I think the previous day or the next day, another patient came in, cussed her out, knocked her computer on the floor, right? And that's why I said, pay attention to who bears the burden of patient rage, right? Because the reality is your front desk staff are typically BIPOC staff, right? And if you're not standing up for them, that's a problem, and it sends a message to the patients and your staff member. So she got to go home paid, and an incident report was filled out, and yes, that manager was talked to. And we are in the process of, I still talk with them and still claim them, some of them as my babies. They are in the process of developing a tool that managers can use, so when those moments happen, I get it that sometimes you want to freeze, and so they literally will have a red card that is laminated that been like, in these situations, these are the interventions and these are the statements. These are the questions to ask. Yes, so before our equity work, it just was going on. It is as a result of that equity work that we got to that point, that they got to that point. So thank you for that question. Yes. So that's a perfect reason. Like, you have to train your leadership so they can respond when these moments happen, because they are going to happen. They are going to happen frequently. And I totally get it, right? Like, we know that our patients are marginalized. We know our patients are traumatized. And just because you're traumatized do not mean that you get to be disrespectful to me. You do not get to emotionally harm me, and I'm supposed to just take it and keep going. When I was in permanent supportive housing, I was in one of the deemed worst housing buildings. Like, even when I went to other permanent supportive housing, when the residents at the other place heard that I worked at this one place, I automatically got street cred, right? Because they were like, "Oh, that's rough. That building is rough. You gotta be tough to deal with that one." And I'm like, those are all my babies. But even in that building, I had boundaries, right? In my office, we don't do certain things, because this is a safe space for me and a safe space for you, right? And I'm a fight to make sure that this safe space for you is always available. But then that also means, in return, you also keep it a safe space for me. And if they having a moment, I'm like, "It's okay, honey." I'm like, "You go outside that door. You had your moment. When you done, come back and talk to me. I still got your juice box and your candy. We good? Right? So yes, okay. So those are tools that you have. We are, let me see, I'm trying to check my time. I know, I'm like, okay. Okay, yes, we have 15 minutes to have conversation. So in the back of you can either choose to make up a scenario on your own, or in back of the racial equity and the one that listed out the whiteness organizational norms, there's a pre-made scenario in the back of here. So I want you to practice role-playing, addressing, disrupting microaggressions, macroaggressions that you see showing up. Because this is a multi-page one. Yeah. Yeah, see, it says naming and framing. There's a couple of different scenarios. So again, you can use a scenario on your own, because I know you got some. Or you can use one of the ones that are in there. All right, my dear beloveds, we are officially on break. If you need to refresh your coffee or tea, you can go out. If you need to check out of the hotel, you can run down and do that. You feel free to bring your luggage. We can either keep it at the front or the back. Yeah, and I will see you back at 11 o'clock.